once we have done some basic markings on the patient's chest, just to identify very specific landmarks, we will then proceed to perform what we call, at this point in time, a 3-incision implant. And this involves an oblique lateral incision along the patient's side, as well as 2 smaller incisions at the base of the breastbone, where the clavicle meets the breastbone, with what we call the suprasternal notch, which is where my finger is at the moment. So a small incision here, a slightly longer one, which is going to be housing the latest version of the device, which is the one which is also MRI compatible. And this then sits in a muscular pouch between the 2 muscles forming one's side, which is the latissimus dorsi and serratus anterior muscle. And it sits in there relatively comfortably, and we position it in a place where there's no tension at all, and where there wouldn't be a problem, for example, if the patient were to be lying on their side. Once we've identified these landmarks, we've made the incisions, we would then tunnel the lead, which lies subcutaneously in what we call a fascial plane. Once the lead has been positioned, we will then connect it up to the generator and then fit this snugly into the pouch which we formed earlier when the initial incision was made. The incisions are then closed, and we then check whether the device is able to detect ventricular fibrillation after we have artificially induced it with the device itself.
Speech detection, charging up to 65 joules.
So commonly we do a 50-80 joule shock, and this then induces ventricular fibrillation. The device then has to sense the ventricular fibrillation, and we need to look and make sure that it is sensing that and making a correct diagnosis, and therefore act appropriately by presenting the patient with an electrical discharge, which will then terminate the life-threatening rhythm and put the patient back into their own rhythm. So those are the basic steps involved in the implant.